Good morning and welcome. Thank you for joining our OncLive webinar in partnership with the American Society for Clinical Pathology on the impact of COVID-19 pandemic on laboratory and testing practices, an update for pathologists and lab professionals. I'm your moderator, Daria Zangari, a scientific director for OncLive, and I'm happy to be with all of you. The mission of this webinar is to provide our listeners with a free-form discussion on how laboratories have been impacted and the measures they have taken during this pandemic. We will cover a list of topics that our faculty will go into greater detail on, sharing insights from the front lines. As you can see from this slide, we will be discussing a variety of topics today, which include testing for COVID-19 and the impact on pathology labs, the blood supply shortage and its impact on hematology oncology patients, managing the lab during the COVID-19 pandemic, best practices for continued testing, the collaboration among oncologists, pathologists, and other medical professionals, the impact on the particular type of test that's being ordered, and the importance of continued testing in patients with cancer. So before we begin, a couple of quick housekeeping notes. If you are listening to this webinar, we encourage you to submit any questions you have, and we will try to answer as many of them as we can during the Q&A portion of this webinar. Also, to expand your video player to full screen, click on the icon on the lower right of the player. Hit escape on your keyboard to revert back to the smaller player. Unfortunately, Dr. Carolyn Compton is unable to join us today for our panel. We do have our panel here of 3 distinguished experts joining us, and I'll ask each of them initially to introduce themselves and give their title, affiliation, and a little bit of background about their involvement in some of the research and initiatives they have been involved with pertaining to COVID-19. Dr. Longshore, I will ask you to begin.
Okay, thank you. I'm very pleased to be with everyone today. My name is John Longshore. I'm the Director of Molecular Pathology for Carolina's Pathology Group and Atrium Healthcare in Charlotte, North Carolina. My laboratory is involved in testing for solid tumor oncology, hematologic malignancies, genetics, and infectious disease work. So we have been playing a large role in the response of my healthcare system to COVID-19 by performing a lot of diagnostic testing using 3 different methods in the lab.
Thank you. Dr. Milner?
Hi there. My name is Dr. Dan Milner. I'm the Chief Medical Officer of the American Society for Clinical Pathology based in Chicago. And our role at ASEP during the pandemic has largely been in communicating with the laboratories around the country about guidelines, information from the government, cutting edge information on how to move forward with the labs, but also directly communicating with the government around efforts to improve the ability of our lab professionals and pathologists to do their job, including, for example, remote sign out, access to EUAs, and most recently a push for a national testing strategy.
Great, thank you. So we'd love to hear about some of those initiatives later on as we go through. And then Dr. Sanford.
Good morning. I'm Kim Sanford. I'm actually the medical director at Virginia Commonwealth University in Richmond, Virginia. I am the medical director of the blood bank, and also I perform apheresis procedures on patients. My role in the COVID pandemic has truly been involved with managing our blood supply during these very trying times, also in an effort to try to increase blood donations throughout our Commonwealth, and also provide convalescent plasma for patients who are suffering with COVID-19. Thank you.
Great, thank you. Thank you, everyone. So we have a great deal of material to cover this in this discussion, so let's begin. So to start us off, I would like to provide some very quick numbers on the current state of COVID-19. Currently, to date, the number of global confirmed COVID-19 cases are over 2 million. The United States officially has the most confirmed cases at over 700,000, with over 34,000 deaths. Nationwide, social distancing measures remain in effect, and we are all encouraged to follow national and local guidance. More recently, the federal government has drafted a 3-phase approach to reopen the economy in regions that have experienced a 14-day decline in cases. So while we all have been affected by these measures, we must take the time to acknowledge and recognize those that are on the front lines. Our pathologists and laboratory professionals are working tirelessly to ensure patients are receiving correct tests accurate diagnosis during these times. Their contributions cannot be overlooked, and today we are here to discuss how they have adapted to these times. With that, I would like to turn it over to one of the first topics of discussion, which is going to be diagnostic testing for COVID-19. And I am going to ask Dr. Longshore, would you please elaborate a little bit on how your lab has adapted to testing for COVID, what the process looks like, and what types of tests are being done in this situation?
Oh, thank you. I'll be happy to start our discussion today. Many labs, healthcare systems and local labs have been interested in performing localized COVID-19 testing to help with the global pandemic, but we were not able to do so until the guidance from the FDA allowed us to do so on the 29th of February. So my lab, along with many others across the country and around the world, have been working to develop our own laboratory-developed methods that can be submitted to the FDA for emergency use authorization, in addition to working with commercially available methods from our large IVD manufacturers who have come online with multiple test methods that have emergency use authorization. So our first method, for instance, in my lab went live on March 9th. We followed with our second high volume automated method on the 17th of March, approximately 1 week later. And our third method, another high volume automated method to support our increased capacity for testing volume, went live last week. So it certainly has been a group effort among our entire laboratory to support the molecular area. We have lots of technologists who are coming in and volunteering from other areas of the acute lab and other specialty areas to help us perform the testing. And a big partnership, in addition to perform this RNA-based testing for the virus that is used for diagnosis, considering many of the problems we've had with reagent backorder shortages, PPE shortages that everyone is hearing a lot about in the lay press, in addition to supplies, anything from plasticware to reagents that we need, N95 masks, P100 filters that we use on a daily basis for those of us that do respiratory virus testing.
Great, thank you. Dr. Milner, do you have any comment on this?
Yeah, thanks, Daria. Thanks, Dr. Longshore. I think one of the things that has been fascinating as we talk with our colleagues around the country is, as Dr. Longshore was describing, the fact that they brought 3 different platforms online for their laboratory to meet volume needs. In discussions I've had with other lab directors, they've brought on 4. One program has 7 lab directors. One of the networks here in Chicago has 3 different tests online. And I think that is a challenge from the point of view of our standard operating procedure in the laboratory. The way that we like to approach laboratory testing, as everyone in the audience who's a lab professional and pathologist will know, is to have one test that we validate, that we use that as our primary method, that our clinicians can depend on that result. There's no problem with interpretation. There's confidence in that result. And when you have 6 or 7 methods, or even 3, which appears to be the average that we're seeing, we have concerns about the communication and the stress that puts on our lab professionals and our pathologists to try to implement that with their LIS, to answer questions for clinicians that's coming through, difference in reference ranges, for example, et cetera. So I find this to be a fascinating response from our laboratory professionals and our pathologists and our labs around the country of how they chose to do that, which I think is extraordinary and heroic. But I think it's important to recognize that isn't how we would want to do it. What we would really want to do is have a method with ample supplies to be able to do that and offer that, which is fitted to our patient population. But in this pandemic time, we've really had to relax what we would accept and do this just to meet the needs of our patients.
Great, thank you. And so the 2 good points there. One being Dr. Longshore brought up. So how is the PPE shortages being navigated from a lab perspective?
That's a great question. From the lab perspective, we were fortunate that my lab routinely performs respiratory virus testing. So most of my employees in the molecular pathology lab are already fit tested for using either N95s or half mask respirators with P100 cartridges. We have a couple of individuals who have PAPR respirators because they have beards. So it's a wide variety of personal protective equipment that we use to protect us from a respiratory infection, in addition to performing these setup of tests under a class 2 hood for safety, in addition to gowning up, gloves, goggles, face shields. So really standard PPE that we routinely use for working with respiratory viruses. We haven't had to have a lot of changes. What has been a challenge for us is meeting the needs of PPE, where we have had to qualify additional teammates in our laboratories to perform testing. It's been a challenge because of the global pandemic. You know, PPE needs are not unique to Charlotte, North Carolina, the U.S. It's a global issue where this is a global pandemic and there's only so many that can be made. And we've had to look at options to potentially reuse some of our respirators, try to extend the useful working life whenever possible. So it really is not only a current challenge, but will be an ongoing challenge as long as we're dealing with the global pandemic.
Thank you. And Dr. Milner, you also mentioned 3 different testing types. So how has that, possibly affected outcomes or interpretation of results? Is that, have an impact on that?
So I think we just have to state the obvious that is a challenge. If you have 3 different systems, every person performing that test, every pathologist or medical director overseeing that lab needs to understand the parameters of those tests and be able to explain it to the clinicians who quite honestly don't really have the time or the know-how to figure it out on their own. They're too busy taking care of those patients. And so I imagine one of the major challenges would be the need to communicate so frequently. And we recognize that off an average of 3, that's going to be a problem. But for labs that are really pushing up into the 4, 5, 6, 7 tests, that this is going to be a major challenge. We have had some help. CDC's guidance, their website has excellent guidance, and that CDC guidance has included information about handling and safety, biosafety in the lab, et cetera. It hasn't really addressed multiple test platforms and how to do that, but it's not something that we necessarily would have encouraged, but it's just what we're having to do. And I think CAP guidelines normally, which require PT quite frequently, internal controls quite frequently, and obviously labs have to be accredited by CAP. They have relaxed that on their guidelines on their website, which is extremely helpful to these labs right now so that they can actually focus on getting the lab tests done and making those critical communications with the clinicians.
Great, thank you. And so, yeah, you touched on it. So a little bit about the guidance that has been out from the CDC. And we also have, I've just seen in the news that recently the ASEP has called to action for the federal government. So if you would speak on that, what are those efforts looking like? What is going to be the importance of that and the impact?
Thanks so much. We have put out a national request, a call to action to obviously all to our members, but also to all of our citizens to really demand from the US government that we have a national testing strategy. And what does that mean? Well, we really need to have an organized approach to how to do this. We shouldn't be seeing 3 to 4 to 5 to 7 test platforms happening and saying, oh yeah, that's the right response. We really should have a coordinated way to do that. And so part of this demand is really for communication between the government, between the lab agencies, between the medical societies and the other groups that are involved in coordinating that so that we know from the beginning exactly what each person should be doing. If you imagine, take any industry partner who creates a lab test or has a lab test platform, they know at any one time how many machines they have out in the country. They can tell you the capacity per day of those machines. And so if you can coordinate with each industry partner, you really can understand that entire national testing volume that's possible and really strategize, providing sequence so that RT-PCR can be developed across those platforms. And then each lab can be correctly supplied so that the volume is there to meet the needs that they have. There's also a couple of other important things, which we have had some victories already: flexibility with CLIA guidelines, some relaxation. We heard, as I mentioned earlier, from CAP. These are things that allow, in a stressful pandemic time, for the labs to be able to cope and not have to deal with, we won't call it unnecessary, but we call things that are necessary when we have the luxury to do them. But when we don't have the luxury to do them because of critical ill patients, we have to focus on the testing. And I think the last important part of our call to action that is really crucial is financial support. We did see a wonderful CMS announcement about doubling the reimbursement, which is great. It's hard to know if that will have impact immediately or in the long run. But if we think about it, when we focus everyone on COVID, other things go down. And we know from our AP colleagues that their anatomic pathology labs, which is where our cancer patients are getting almost all of their diagnoses, they're really suffering. Surgeries are elective, volumes are down, and those labs need support during this time in order to get through, so that on the other side of it, we can start right back up again with our cancer care and our cancer diagnostics. And that's, again, part of a national testing strategy to say, as we push to do this testing, prioritize, we will support this other testing or these other platforms in the meantime, so that it can continue and start right back up again. You can imagine if we suddenly have, we worry about our restaurants not coming back online, but what if our labs don't come back online? That would be a serious problem for our cancer patients. And so during potential pandemics, which we know are going to happen, support financially is also really crucial.
Great, thank you. And Dr. Sanford or Dr. Longshore, do you have any additional comments here?
Yeah, I wanted to add, so I'm in the blood bank, and so we have a very different sort of work environment than what Dr. Longshore talked about. So in our laboratory, we've always worn basically water impervious sort of lab coats that button down the front and gloves. And that's really all that we've worn for protective equipment. This whole experience has brought to our attention that the distance between our coworkers was not within that 6-foot distance at all times. And there was concern from the laboratorians as well. And so we had to implement that all of our technologists had to wear face masks. They could be cloth face mask or the P100 mask. We didn't want to go to an N95 mask, but just sort of like what you would use in sort of a green zone, if you will, or a low infectious facility. The other thing we experienced at VCU was that most of our testing was performed in our microbiology laboratory. We needed an additional test to be brought online so that we could offer testing for our preoperative patients. We've tried to reduce as many of our elective cases as possible, but there are a number of procedures that just can't be put off. Liver transplants is one of them. We've done an unbelievable number of organ transplants still during this pandemic, and we needed to get testing for these patients before they undergo transplant. So we implemented a test in our molecular diagnostics lab, like Dr. Longshore, and the results from that were very different. And so we didn't actually look at what those results looked like. We just left molecular to create their own result pathway, and microbiology had their own pathway, and microbiology had been up first. And so when the clinicians started receiving the results from the molecular diagnostics, they were very different, and it created a lot of confusion. And so, it is hard, and we also get testing performed by LabCorp of America that we also, if people want to have testing as an outpatient, can offer that as well. So it is hard, and we've had to go back and restructure those results to minimize the confusion from the clinicians who are getting all of these different results from 4 different assays that we're using. So it has caused a lot of confusion in our environment as well.
And I will add in, based upon what Dan said earlier, I think ideally we would all like to have a single assay that we're running in our labs to support COVID testing, but we've all been forced really to adapt to multiple methods to minimize the potential supply chain interruptions we have. Our manufacturers are working hard to meet our testing demands. The federal government, and in particular FEMA, is involved in determining where many of the reagents are supplied in hotspots around the country, so it is certainly a challenge. And in addition to that, each test is different with different reporting ranges, different sensitivities, and the 3 tests that we have working in my lab, we have a single target test in the COVID genome, we have a test that looks at 2 targets in the COVID genome, and we have a test that looks at 3 targets in the COVID genome. So it can be very confusing. It takes a lot of communication and work with your clinicians to understand how to interpret and best use the laboratory results.
Great, and we do have a question that just came in. So Dr. Longshore, what type of tests are being done beside RT-PCR for COVID-19 diagnoses?
Well, for diagnoses, the gold standard and really the only technique that has been endorsed is an RNA-based PCR, and this is looking specifically at the RNA from the COVID-19 genome, looking at specific targets in that. There is some talk that I'm sure we will get to toward the end of the webinar, looking at serological testing, which really is not appropriate for diagnosing patients with a COVID-19 infection. We require the RNA-based virology test for looking to diagnose a patient with COVID, but I'm sure we will talk more about potential for use of serologic testing as we get toward the end of the webinar.
Great, thank you. So that was very great insight from everyone. So now that we've discussed testing, we are going to turn our focus over to the blood supply shortage and the impact that that's having on our hematology oncology patients. So this would be Dr. Sanford's area of expertise. So it's apparent in these unprecedented times that due to the number of hospitalized patients and those in intensive care units, that blood is in critical demand. So Dr. Sanford, would you just give us your thoughts and comments, on the updated guidance, what this means for patients, how this is going to be impacting our hematology oncology patients?
Sure. So I have to say, in probably about the second week of March, we experienced our most significant blood shortages, and that was due to thousands of blood drives being shut down across the country due to the fact that large businesses, universities, and high schools were being closed. It resulted in a deficit of hundreds of thousands of units of blood not collected. And at that point, we really we were very quick in forming a blood conservation task force in our hospital. So I helped to lead this with a group of surgeons, as well as our oncologist, our sickle cell anemia team, and our pediatric partners as well. So we basically created an emergency blood management supply policy of how we would handle this. We first also worked with our trauma team. We're a level 1 trauma center and use a significant amount of blood in that arena as well. So we had to do a lot of things to, first of all, consolidate where the blood products were, because we had them in multiple locations throughout the hospital, and we basically centralized our blood products back to the blood bank, and then reduced our number of blood products for each phase. So we have a massive transfusion protocol that determines a number of blood products in each phase in certain ratios, and we reduced those in half for all of our trauma patients. So it was really, those first couple of weeks were very difficult. We were not getting replenishments. All of our scheduled blood shipments were being cut in half or being postponed to the next shift. So that was really incredibly significant. I have to say that many of the blood collection organizations, as well as the AABB, which is our blood bank national organization, and ASEP all brought together highlights to the community that we really needed this blood desperately. When we worked with our oncologists, we basically, they were also trying to make sure that they had the proper social distancing in their clinics. So they actually started to stagger a number of their clinic visits, and we also reduced our sort of thresholds for transfusion in this patient population as well. We've also moved to telemedicine to prevent a number of patients from actually entering the hospital, the patients who are vulnerable populations. And then in our sickle cell patient population, we also basically converted some of these patients from a full blood exchange every month to increasing that time between exchange transfusions, where we change out all of their red cells from like 4 weeks to 6 weeks, or in some cases up to 8 weeks. We converted some of them to just receive a simple unit or 2 of blood instead of receiving 6 or 7 units of blood, where we change out their red cells altogether. So it had a huge impact, and it was felt hospital-wide and community-wide, as many of our patients were basically told, we're going to have to rethink how we're treating you, and we're going to have to reestablish some different guidelines for treatment.
Great, thank you. And Dr. Milner, Dr. Longshore, any comments?
I would just add that, you know, the transfusion medicine and the blood bank have always been my heroes from the point of view of what they have to do during a regular work day. And I think with the pandemic, with the shortage of supply, which is always a problem with the blood supply anyway, where we're always in need of blood, it's really important. I think the Surgeon General even said it's totally safe to donate blood. Please go donate blood. I would also echo that message, but also remember that convalescent plasma, which Dr. Sanford mentioned earlier, is also the purview of the blood bank. So it's not just that they need help to support their regular activities for their regular patients, but they are participating in the treatment of COVID patients as well. And so we have to really thank them all so much for the work that they're doing, along with all of our lab professionals, and during this trying time.
Great. And Dr. Sanford, would you care to comment on the research you're doing in convalescent plasma?
So we actually are working with our blood supplier in order to, first of all, secure convalescent plasma for our patients. We have an infectious disease physician in our facility who is identifying appropriate patients to refer for convalescent plasma usage. We also are using an emergency IND, which is a form that you have to fill out and complete and send to the FDA that allows for you to transfuse this patient with convalescent plasma. Once that's filed with the FDA, our blood supplier receives notification and can provide that product to us. At this point, we are still waiting. It also required us to actually build these products. So you have to have a very different code that is labeled on your unit before you can actually send it. And that code has to be FDA compliant. So we had to receive these codes in from our blood supplier and be able to send that out to our patients. So again, all of this has required a lot of information technology support, not just with the COVID testing and all the different platforms that had to be built into our electronic medical record, but also for these new products that have to be provided to the patient. So there's been a tremendous amount of work, and it's just been a ripple effect for everyone in the healthcare industry.
Thank you. And so how would you, portray that? So if someone does have COVID-19 and they are recovering from it, how would you promote them to go donate blood and on that accord so it can be used, or how is that being portrayed?
Yeah, so we actually provide them with a link where they can actually go onto a website and see if they qualify as a convalescent plasma donor. There are some criteria that have to be met. Not only do you have to meet the regular donor history questionnaire requirements that each person who donates a regular unit of blood, but you also have to meet these additional COVID test results. So the blood supplier that I currently use does require one positive test, followed by 2 negative tests, and then symptom-free for 14 days before you can serve as a convalescent plasma donor. There was some discussion about testing these patients for their serologic antibody, as well as what the concentration of those antibodies levels were, to sort of ensure that people would get a protective level of antibody when they were transfused. That has, and at least in the blood supplier that I'm dealing with, that has not become a requirement. So I know that I've looked at some other blood suppliers, and they are looking at antibody concentration levels and setting thresholds that those donors would have to be above, so that if you're transfusing these antibodies, you want to make sure they're at a high enough concentration to provide a passive immunity for these patients. But our blood supplier that we're using does not require that.
Great, thank you. And so now we'll move on. This is all excellent insight. We'll move on to the management of the lab and best practices. And I think, Dr. Milner, you had mentioned this a little bit earlier. You had spoke to a few medical directors on, you know, what type of precautions they're taking, what has been implemented, you know, to protect our lab professionals, safety measures. So if you would just like to discuss some of those areas.
Thanks so much. Yeah, so as I mentioned, I have had an opportunity to speak with some of our lab professionals that direct very large lab systems, as well as some of our medical directors. And in addition to the multiple tests, which Dr. Longshore mentioned, some of those mentioned up into 5, 6, 7 tests, they also did talk about what they're doing to protect themselves in the laboratory and their staff, as well as what's a hospital-wide approach versus what they're specifically doing in the lab. And what I found fascinating was that 3 different lab groups that I talked with in 3 different states mentioned that they were using a shift approach. Basically, they have completely separate teams that don't interact with each other, but come into the lab for, say, a 12-hour shift and then go home, and then someone else comes in, and that minimizes the crosstalk or the cross-contamination between them, so that if someone is exposed, it's not exposing everyone in the lab. And what's fascinating to me about that is that was a lesson learned from Nebraska during the Ebola outbreak, you know, from a previous potential pandemic. And some of the labs directly copied Nebraska's approach for that, but other labs de novo came up with that idea, which is really interesting that it's just really the logical thing that you would do, and that they were able to pivot and shift their staff to give them things they could do from home and work from home, so they're not having to reduce their compensation. They're still contributing to the laboratory's productivity, but still having this shift approach, which is really great. The other is social distancing. As we know, labs are small spaces. We often always are arguing with the hospital to get more space for our labs and windows. And I think that that's really a challenge in a laboratory to do social distancing, but they've been achieving it by reducing, for example, the number of chairs in break rooms, by alternating cubicles, by alternating surgical benches, for example, and then just creating, you know, rules and spacing between them. And that, again, that's to protect them, their workforce, but also to protect individuals from getting ill. And then masking. Several hospitals that we've talked with have universal masking for everyone. Definitely masking while working with COVID samples is required, but also face shields and hoods, as Dr. Longshore mentioned. So really taking the advice that Dr. Longshore's lab would have about any respiratory pathogen and really expanding that to almost your regular work day in the laboratory, because you never know what sample may or may not have been infected, and so it's best to use that precaution. So really great, insightful information from our members across the country as to how they're doing that protection, and really instilling confidence in, you know, obviously in their ability to do their job, but also adapt to the need to protect themselves and the patients.
Great, thank you. And Dr. Longshore, I saw you shaking your head there. So if you'd like to comment on some of those, you know, topics, items.
Yeah, it certainly is a challenging time to figure out how to manage a diagnostic laboratory with the COVID-19 infections. And we've used many of the topics that Dan mentioned earlier. We have gone to 12-hour shifts, non-overlapping teammates. So there's a minimize of crosstalk or the ability to, you know, carry an infection from one shift to another if someone is potentially infected, because we're not only obligated to keep our staff safe at work, but they have families as well. We want to make sure they do not have an occupational exposure and take something home. In addition to that, we are performing health screens on all of the laboratory teammates when they walk in the door at the beginning of their shift. And this is a temperature screen plus a series of questions. And then they are issued a surgical mask to wear for the duration of the shift to help minimize any potential problems that could arise from the lack of social distancing that has to happen in some laboratories because of the tight confined spaces that we work in. But we certainly do try to encourage social distancing as much as possible. But those are some of the more specific methods that we have tried in our own facility to take care of our teammates.
And so have any tasks that are done in the labs, are they able to be done at home at all? So, you know, I know a lot of doctors are doing telemedicine and this and that. So what, you know, are there any types of things that can be done remotely?
So thanks, Daria. So one thing that is obviously happening, and I mentioned it or alluded to it a little bit earlier, is that there's need for more communication. There's SOPs that have to be written. There's documents that have to be completed in order to, you know, validate these tests, et cetera, et cetera. And that's sort of some of the work that can be done from home. For example, writing up the SOPs or any of the paperwork to support the functionality, the quality of the lab, compliance with future inspections, et cetera. But from the point of view of testing the patient, you know, unfortunately, samples have to be run in CLIA laboratories, and that's you know, the whole point of CLIA is that physical building space is a designated space for lab performance, for biosafety reasons, for you know, clinical communications, et cetera. So some of the jobs cannot be, and that's why, as Dr. Longshore mentioned, these 12-hour shifts of people then being at home off is really the way to do it, rather than say 4 hours at work, 4 hours at home, because not much you can do at home. But when you are at home, there are some limited tasks that can be done. This is also stresses back the importance of this remote sign-out concept that we mentioned earlier, where pathologists, anatomic pathologists who look at cancer biopsies and cancer cases every day with digital technology now could sit at home and review those cases. The FDA is still working its way through the legality of that from a billing point of view and a standards point of view, but that has been relaxed in this pandemic so that pathologists can remotely sign out to increase social distancing, to keep the workflow going. But we fully expect that when this is over, we will go back to normal sign out, and we will wait for the FDA to make that an official policy before it would be something people do all the time. So I appreciate that has happened. We worked really hard with the government to make sure that relaxation happened. That was an ASEP-led effort along with others. But we do recognize that it's a pandemic issue. And so I think each laboratory can decide what can be done at home, what people can contribute at home, and then what they really have to do at work, and then make the work schedule go accordingly.
Great, thank you. And so are tests being prioritized in a certain manner? So, you know, you have your routine testing versus diagnostic testing. Has that been implemented at all?
I'll be happy to try to answer that. It's really been a challenge to decide how do we carry on with our routine diagnostic testing. One thing that we have had to do, not necessarily because of personnel able to perform the testing, but because of the dramatic shortages that we're seeing in test supplies, reagents, plasticware, and PPE, we've had to take an approach to look how frequently do we really need to be performing testing so that it's still medically actionable. In other words, tests that we've been performing on every shift, is it acceptable to only perform them once per day now rather than 3 times per day? And tests that we've been performing every day, can we perhaps decide to perform them twice a week or 3 times a week? So it increases the turnaround time slightly, but hopefully that does not have a large role to play in the medical management of a patient. But it's not an easy time because of these reagent, plasticware, and PPE shortages, but we do have to prioritize testing to what is absolutely medical and medically necessary, and try to emphasize the things that have the most direct impact on patient care.
Great, thank you.
And I would just add that, so it's a really great question, and I would just add that, you know, doing a COVID test for a patient is not the only thing you do to treat that patient. And so as you would expect, blood gases have been reported as going through the roof, like more and more blood gases being ordered because of the respiratory symptoms that patients have. One of our lab directors reported that they have shifted almost all of their viral testing, except for COVID, to a reference lab because they just don't have the capacity to do both. And I think this gets back to the comment about the national testing strategy we made earlier, which is that you need there's this concept of surge capacity. You know, how much capacity can a laboratory afford to have in any given situation? How many extra samples can they take in? And in our global health work, we see labs that work at 100% capacity all the time. They simply have no surge capacity. But in the US, we know there are labs that probably operate about 25 to 50%, and they have surge capacity. And so this is a really crucial aspect of this coordination, is that if we know where that surge capacity is, then we can tell our medical director, hey, switch to COVID, send the rest of your viral testing to lab X, and lab X has the capacity to cover you, and then to another lab director, they would send to lab Y. So not everyone is sending to lab X. And that again is this important aspect of meeting this shift in demand, or the shift in need of doing testing, or rationing testing, however you want to describe it, is knowing where your capacity is and being able to reroute that capacity to the places that can handle it.
Great, thank you. So just switching gears a little off of COVID testing, and you know, as you spoke, there is other type of testing that's going on. So in patients with cancer, and just specifically testing how that may impact these patients, you know, do you find that there's been an impact on tissue-based or liquid-based testing? So, you know, if patients aren't getting, you know, the biopsies, are they getting more liquid-based tests? So is there an uptake there, and the impact on molecular testing as well?
Right. We do a large volume of molecular oncology profiling and biomarker testing in my lab. In addition to the COVID work we're doing, it seems like everything's COVID now, but patients are still getting sick with other conditions, and cancer patients, it's important that we certainly take time not only to diagnose them, but to stage them appropriately and also to determine what particular targeted therapies they may be eligible for. So we have really tried hard not to have an impact on our turnaround time for our oncology-based testing, whether it's something as a routine viral load for a bone marrow transplant patient undergoing immunosuppression, or something as sophisticated as a next generation sequencing panel to look for targeted therapy options for patients with solid tumor oncology disease. We've tried very hard to minimize the impact of our COVID testing on that, and so far it has worked out very well.
Great, thank you.
And I'll just add, thanks so much, Dr. Longshore. I think one of the expected comments that we had earlier, you could almost predict, is that surgeries are down, resources are being diverted in the hospital to care for COVID patients. And even though I would argue that a cancer biopsy or cancer surgery shouldn't or should be classified as elective, these are the surgeries that are being delayed, or patients are being delayed. And so volumes are quite down in anatomic pathology, and hopefully, that will return to normal once the pandemic is over. But the good news, I think, is that was a temporary situation because of the need to adjust to COVID. And speaking with my oncology colleagues, both in global health and in domestic oncology in the last week, they have reported that they are starting to go back to take care of their cancer patients. They're starting their clinics back up. They're starting routine biopsies or selective biopsies back up in the next week or two. And so I think we have had a hiatus of what we would like to be doing for our cancer patients, which was necessary in order to adjust to the pandemic. But it looks like, at least from some anecdotal conversations with quite a few very prominent oncologists in the country, that they are starting to open their services back up. And I think that means that we will start to see an uptick in AP and these other services that support cancer, which is very exciting for our pathologists who've been stressed with trying to figure out how they can help when what they normally do is diagnose cancer, and it's not an issue for COVID at the moment. But I think, again, that gets back to the again, not to harp on it, but the national testing strategy push that we have, and that financial support, because we do know that revenue streams being what they are, we have to keep a lab running, even if it's raw materials are not coming in to create its product. And so I think it's really crucial that we consider that and recognize what that capacity needs to be. How long does the AP lab need to be at a low volume to get over a pandemic? Can we reduce that window so that it's maybe a very brief period, and then it is much less costly to support that lab during that low period? And again, that's part of that coordination and planning that we need.
Great, thank you. Thank you, Dr. Milner. And Dr. Sanford, did you have anything to add here?
Yeah, I had a few comments. So in our laboratory, we looked at trying to create some kind of staggered shift or separated shifts. And with our laboratory and the ongoing nature of patients in the operating room, this was not feasible. So we really had to go to the full-time mask and continue with the 3 shifts that have a team huddle, so that they can provide information of what happened on the previous shift to the next shift, because of the way our work flow continues throughout shifts. Some of the other things that we have been doing is now that we have a more high volume throughput test available at VCU, we are performing preoperative screening for all of our surgical patients, and we just started that this week. So all of them have to have a COVID test performed within 48 hours before going to surgery. All positives, the clinician and the patient themselves may defer the treatment or the surgical procedure for later periods of time after they've recovered, particularly if the surgical procedure may, with the COVID virus, may put them in a worse prognostic category. But even the negatives are still being treated as potential positives, because we've certainly seen results where patients were not properly collected, the nasopharyngeal swabs were not good samples, or the patient within that 48-hour window became infected from a contact prior to surgery. So those have been some of the things. Now moving forward in the state of Virginia, our elective surgeries are on complete standby right now until April 24th by our governor of the state, who's prohibited any of us from performing elective procedures. We've been waiting to hear if he was going to extend that time period to May, and we still have not heard any extension at that point. So people are starting to try to put up plans for continuing to do this preoperative screening. Of course, you have to have a facility and a place where you've trained personnel how to actually perform this this sample collection properly, so that you ensure a good sample so that you have accurate results. And then again, making sure that they can come to the hospital, because we are the largest tertiary medical center for within an hour of our of downtown Richmond. So trying to make sure that we make arrangements for that. The other thing that concerns me is if we continue to, or if we move forward with elective procedure cases after April 24th, what is this going to mean to our blood supply? One of the reasons that we were able to replenish our blood supply is that we had over a 60% reduction in usage because of canceling preoperative surgical procedures, or these elective surgical procedures. So that really helped to bolster our blood supply. So my concern is that, you know, people are going to start performing surgery 7 days a week now to take care of this backlog of elective cases. And are we going to deplete again our blood supply? So that's one of my biggest concerns at this point.
Great, thank you. And so would you just discuss a little bit about the deferment and some of those requirements of patient populations that have been put in place?
Yeah, so we have been really excited. We have all blood bankers across the country and worldwide have been in opposition to some of the imposed deferral periods, which were set up in some cases 20 and 30 years ago when we didn't understand transmission of a lot of different viruses. So some of the ones that I'm really pleased about is for basically high-risk behaviors, the nucleic acid testing for HIV, hepatitis C, and hepatitis B. A lot of these deferrals now are 3 months instead of indefinite or 1 year deferrals. So we know that if patients have abstained from a high-risk behavior for 3 months and they come to donate blood, we should be able to detect any sort of, you know, basically transfusion transmitted disease process, predominantly HIV and Hep C, within that 3 month period. So that was really one of the things that we are very happy about. Some of the other important strategies that we are really happy that the FDA has provided a reentry pathway for people who spent long periods of time in the 80s in European countries. And we are so very pleased because we know that there are a lot of deferred donors who were in the military in the 80s who now cannot, have been permanently deferred from donating blood. There is now a reentry pathway for these donors, and this will really help bolster our blood supply as well. So we're very pleased with these, with the repeal of some of these deferrals, which quite honestly were not evidence-based. So we're very happy with that.
Great, thank you. So before we head into the question and answer, because we are getting to the end of the program, I would like to ask the faculty if they have any other comments or topics they'd like to make. We do have a bunch of questions, so we'll try and get to as many of those as we can.
I have one thing I would like to talk about. I think, you know, the elephant in the room, so to speak, that many of us deal with on a year-to-year and day-to-day basis is the challenges we have with the laboratory fee schedule and reimbursement. And that has caused many of us to have to go to a lean operating environment or a just-in-time delivery environment, not maintaining large stockpiles of testing supplies or testing reagents to, you know, help the bottom line, so to speak. When we have a global pandemic, there's no such thing as supply chain security. So it really, I think, is going to cause us, after this is over, to have to take a hard look at the way many laboratories and medical centers carry on with business. And does it make sense for us to have a strategic stockpile of crucial supplies and reagents for future scenarios such as this? Or do we go back and continue to work with a just-in-time delivery system and assume we're never going to have this? But I think there's going to be a lot of hard questions that we have to look at the way we have done business over the past couple of decades and the way we've been forced to do business over the past few years after this is all said and done.
Great. And Dr. Longshore, so we do have a question, a couple of practical questions for lab management, if you would care to comment. We had a question about, you know, the QC processes for reagents and if those would be, you know, less stringent because they are on shortage. And then also when setting up the labs, you know, is there a third party that will come in and evaluate to make sure that they're following appropriate social distancing measures or that they're following safety procedures?
Oh, that's absolutely fabulous question. You know, one of the challenges we have when products receive emergency use authorization from the FDA is there's not a full-blown clinical trial that goes along to help determine, you know, sensitivity, specificity, positive predictive rate, negative predictive values, and such as that, because there's no predicate device and gold standard device. So the other challenge that we have is when we receive these reagents that are so precious, you really want to use a minimum number of the test supplies that you have for performing QA and QC. You want to do the bare minimum that you can to make sure the test is performing as expected up to the package insert standards, and save as many of the tests as you can for performing patient care. So I think many of the reagent manufacturers have worked very closely with CDC and the FDA to have assay implementation plans to help verify performance of an assay when it comes into your laboratory using a minimum number of reagents, but still making sure that we're compliant with all the CAP guidelines. So that's been something that is a challenge, but I think the manufacturers have done a very good job of helping direct us how to effectively use the supplies. The other challenge has been QA and QC materials. There are not a lot of quantitative or qualitative standards available for COVID-19 infections. We know that many of the tests on the market look at different conserved regions in the genome, and it's hard to have synthetic controls made in such a rapid time to allow us to do normal levels of quality control that we normally would for a test. So we work very closely with our quality QA and QC department in the hospital to make sure that we're meeting all the regulatory guidelines before we bring a test online, and also for lot-to-lot validations as we normally would.
Thank you. And Dr. Milner, do you have any comments there?
I would just add that, the question about can someone come in and see that we're doing what we're supposed to be doing correctly? You know, we look to the College of American Pathologists for accreditation to do lab inspections, et cetera. We also look to JCO, they also inspect labs through tracing, et cetera. They are, if we look at CAP's model, they use lab professionals and pathologists for those inspections, and those people are inundated and taking care of patients and doing testing right now. So I think we have to thank the college for relaxing the accreditation requirements and the inspections that they're doing right now. But the truth is that it would probably be really difficult for them to try to do them. And so to find someone who could come in and help you look at your lab and make sure you're doing it correctly would be a challenge. My advice to that person asking that question would be to talk with infection control in your hospital. Almost every hospital has someone devoted to be the infection control officer, and they should be able to read the CDC guidelines, the CAP guidelines, et cetera, and help you make sure that you're complying, but also make sure that the testing is working properly.
Great, thank you. And so we do have a question for Dr. Sanford. So how have you been managing your product inventory given the constant fluctuations and levels of elective surgeries and oncologic patient transfusions? Is there a lot of waste there? What are you seeing?
No, we have very minimal wastage. I thankfully have reached out to my hospital administration, formed a very solid team with my hematology oncologist, our cellular therapy practitioners, the transplant team, our solid organ transplant team, the trauma team, and the OBGYNs. So we meet multiple times a day by Zoom, so remote conference calls with each other to maintain what's happening, what's going on in your environment, what is your strategies for today. So I've created a number of different new policies that we put into place, including this blood emergency management program. And then working with the elective surgeons or the preoperative area or the perioperative area to reduce these elective surgical cases. We take our inventory 3 times a day. I get basically sent to my email 3 times a day. So I'm in constant communication with my lab since March 6th. It's been nonstop every single day of the week for these last 6 weeks. And it's been a bit tiring, but it's absolutely been worth it to maintain constant communication with my staff, as well as to reach out to my colleagues and form. And thankfully, I have to say, I perform apheresis procedures and do stem cell collection, CAR T-cell therapies, as well as performing other types of blood procedures, and have a clinic where I see patients. So it's common to see me in the ICUs performing procedures on patients, as well as in my clinic bringing these hematology, oncology, and transplant patients into my environment. So I am really blessed to have already formed a solid relationship with these practitioners before and have built up a foundation of trust. And I really think that time that has been spent with them really helped to solidify this collaborative professional relationship that we've really created during this crisis. It's been really rewarding.
Great, thank you. And so we have time for a final question. So I'll ask this to Dr. Longshore. So when a provider orders a generic COVID test, or they're testing and they're sending the sample, how do you determine which test is performed on the sample? Does the laboratory make the decision which testing method is used?
Right, the laboratory is making that test decision. You know, for our primary COVID screen, it is allocated by the test manufacturer in FEMA, so we are only able to receive a certain number of supplies to perform that test on a daily basis. So once we have exhausted our number of tests that can perform, we go to a secondary method, another high volume automated method as well, and perform that. The sensitivity and specificity of both of those tests are very close to each other, so we're not worried about potentially missing patients with false negative results or anything like that. But it's really impossible for the physician to handle that order because of the way reagents are allocated to the lab by the manufacturers and by FEMA. We have to be able to control what test is performed based upon how many other samples have arrived for COVID-19 tests each day. So it's certainly a challenge.
Great, thank you. And Dr. Milner, just to conclude, did you have any final thoughts you'd like to say?
Just a huge, huge thank you to all our lab professionals and pathologists across the world and across the United States, especially who are dealing with these problems every day, being our heroes as they always are. We look forward, next week is Lab Week, so we look forward to celebrating them all week next week with Lab Week. And for those of you who aren't laboratory professionals or pathologists, write them a card, send them a note, buy them a bagel, anything to thank them for the amazing, incredible job that they do. The laboratory is the backbone of our healthcare system, and I think we've learned that the hard way with this pandemic, and we need to make sure that in the future that we are supporting ourselves and our laboratories as best we can.
Great, and thank you. So again, I'd like to give a huge thank you to our doctors, Dr. Longshore, Milner, and Sanford, for taking the time out of their days to sit down with OncLive virtually to convey some of these pivotal discussion topics with our audience. Also want to thank our listeners, and I truly hope you were able to gain valuable insight into how the laboratory practices are changing and adapting during this pandemic. I know we did receive a lot of questions, so yes, you will be able to listen back and watch this webinar again shortly following this. Continue to visit onclive.com to sign up for our new e-newsletters, or follow us on social media, Twitter, LinkedIn, and Facebook to get updates on when we will be broadcasting more of these webinars. For all of your oncology news, please visit onclive.com. We do have a COVID-19 resource center. And that concludes our webcast for today. Thank you and have a wonderful rest of your weekend.